Good evening, ladies and gentlemen, and welcome to this webinar being hosted by King Edward VII Hospital, London. My name is Leslie Regan, and I'm an obstetrician and gynaecologist based at Imperial College and at St Mary's Hospital, and also the chair of Wellbeing of Women, the charity that funds research into all aspects of the woman's life course. I'm also the past president of the Royal College of ONG, and during my tenure between 2016 and 2019, I was the author of a report which the RCOG put out, which was entitled Better for Women. And the purpose of that report was to cut through the bureaucracy and the red tape that so often has placed women's health and women's needs at a disadvantage, and to identify the really important factors that contribute to their lives as both professionals and family members. One of the topics that we focused on in that Better for Women report is the appalling problems that women who suffer from endometriosis frequently face. Predominantly, in my experience, both as a clinician and as a policymaker at the RCOG, because they've not been able to access multidisciplinary care from a variety of different specialists who can care for their needs. But the real reason I'm hosting this webinar tonight, which is the second of two webinars on the topic of endometriosis, hosted by King Edward VII, is because I have the great privilege of being a trustee at the hospital and have had enormous pleasure over the last year and a half of watching how the Women's Health Group have really formed themselves into a really helpful multidisciplinary team. So it's with that as a background that I'm going to introduce our fabulous panelists this evening. We've entitled this second webinar is Severe Endometriosis Explained. So we've got some very highly specialist clinicians from different specialties, not all gynecologists, but most importantly, we have our patient. And I'm going to introduce you to Carla Cressy in a moment. She's going to identify herself, I think, on the panel. And Carla Cressy is an endometriosis sufferer. She's a campaigner. She's had great experience with delayed diagnosis of her particular problem. And as she's going to, I think, share with you all this evening, she's undergone major and different surgeries with various different clinicians and suffered from a wide variety of problems. She's now putting all that experience to the benefit of all other women by using social media to raise awareness of her condition, and she's going to be talking about her experience. Thank you very much indeed, Carla. You were fabulous last week, and we had so much wonderful feedback about how incredibly valuable your contribution was. So thank you for coming again to be with us tonight. Our second speaker is Alfred Cutner, a consultant gynaecologist at King Edward VII Hospital and also at University College London. He has a great interest in minimal access surgery, including laparoscopic surgery, but particularly in its application with endometriosis and fibroids, which is the topic of today's or tonight's webinar. And I think what Alfred is going to share with us is the work he's done in developing a really multidisciplinary Endometriosis Centre at King Edward VII to benefit women with complex and not so complex endometriosis. But tonight, as I said, the topic is Severe Endometriosis Explained. And after Alfred's presentation, we're going to move on to Alistair Windsor, who is a colorectal surgeon. He's been involved in managing colorectal aspects of complex endometriosis for many years, for over 20 years. And I think over the last 12 years has been working very closely with Alfred as part of both the UCLH and the King Edward VII Endometriosis Centres. So his perspective from the surgical point of view, working collaboratively with gynecologists, I think is going to be extremely valuable. Thank you, Alistair, for coming and joining us tonight. And then I'm going to introduce you to Darren Smith, who is an endourologist whose practice encompasses all aspects of ureteric surgery, from stones through to injuries, and obviously to the urological support of women who are suffering from severe endometriosis. He has a variety of titles. He's the vice chair of Bowel, the British Association of Urological Surgeons, and many other titles to his name. But I'm not going to dwell on all of that with everybody who's speaking tonight, because I think what we want to do is get on and hear the pearls of wisdom that drop from our wonderful panelists' lips. And last but not least, I'm going to introduce you to what I think is probably a crucial person in the Endometriosis Centre, and that is Renata Marucha. Renata is a specialist nurse who has enormous experience in looking after women with complex endometriosis, and indeed, and they also have simple endometriosis. So she looks after women with this problem from the early stages through to the late and the most complex ones. I think it's often very important that we flag up how important support from really highly specialist and experienced nurses are. And I think that she's going to, in her presentation, be sharing with us some of her expertise about that and what she's learned from it. But Renata, thank you for joining us tonight. We're really delighted that you're here. So I think without further ado, I'm going to remind everybody that if they'd like to raise questions, they can put them into the Q&A box or the chat box. Barney Baxendale, who's helping us and sorting out all of the IT behind the scenes, is going to be filtering these. And when we come to the end of the 5 presentations, firstly Carla and then our 4 specialist panelists, we're going to go through some questions. If there are some particularly pertinent questions at the end of each of the talks that are particularly relevant to what that speaker has brought out, I'll try to highlight them at that point just to keep them into context. So I don't want to spend any more time wasting this precious webinar with chat from me. So I'm going to move straight on to Carla Cressy. Carla, thank you so much for coming and sharing with us your experience tonight. The Zoom platform is all yours, as they say.
Thank you, Leslie, and thank you for having me again. So, gosh, where do I start? So I found out kind of how severe things had kind of become shortly after I was diagnosed with stage 2 endometriosis. It turns out a lot of the endometriosis was unfortunately missed. And 6 months after I had that surgery, I was taken into hospital with, again, severe pain and just horrific symptoms. I couldn't stand up, I couldn't go to the toilet. I would have these pelvic pain attacks that would end with me being curled up in a ball on the floor, being sick, and it was awful. So I was taken to my local hospital, and their doctors there, they were amazing, they actually saved my life. But they thought I had appendicitis. So first they removed my appendix, but then it later turned out that it was actually endometriosis. So that's when I got my diagnosis of severe endometriosis, and I had a frozen pelvis. So from then, I'd already been under care of 4 general hospitals by this point. So it was that at that point I was referred to a specialist centre, which is when everything changed, and I just wish that I had found them sooner. So once I went to this specialist centre, I was met with doctors who understood. They didn't kind of question how long I'd been bleeding for, whether or not I was sure if I was bleeding for that long, or whether or not my pain was really that bad. It was a huge relief to just sit down with somebody and not feel like you're just wasting their time. So it took a while to plan my surgery, which I had last October. There was a lot of different doctors involved. I had a multidisciplinary team, so I was under urology for my bladder symptoms, colorectal for my bowel, and gynaecology for my kind of pelvic symptoms. So by this point, my symptoms were so severe, I didn't even have a day off. I mean, I would bleed constantly, even through the medical menopause medications. They didn't work. They did in the beginning, but after a while I ended up having to take a pill 3 times a day alongside it just to try and get some relief, but that would only really slow down my bleeding. Everything else, my bowel symptoms and my bladder symptoms, they just persisted. I couldn't at this point pass bowel movements. I was having to take all kinds of stool softeners to basically just give myself diarrhea so that I could go to the toilet. My bladder, I felt like I constantly had cystitis. I'd always have urine tests for infection, but they were always clear. I would try and treat it with cystitis relief, but it never helped. So the pain was just so severe, it affected kind of sleeping. I had pain in my lower back that was so bad I couldn't physically sit here for longer than 5-6 minutes without being in agony. Again, going to the toilet, I'd often pass out after a bowel movement. I would go sometimes up to 3 weeks without a bowel movement. I was often hospitalized for that and having to have emergency enemas, and it wasn't nice. So I had a lot of MRIs, pelvic exams, which were incredibly painful. They always have been. And I was, well, I'd say lucky. I know that it's quite normal now at these specialist centres with the kind of technology that they have and the expertise doctors that they have, that my endometriosis showed up on all my pelvic exams and my MRIs and my scans. So I was quite lucky there. But 6 months prior to that, well, probably 3-4 months prior to that, I would have these same exams at local hospitals, general hospitals, and nothing was ever picked up. So from just going to that centre, everything was just explained, and like they just knew what to do and where to go next. I spent many years not knowing who to turn to, where to go, what to do. So that saved my life. So yeah, I first had a laparoscopy just for the doctors to take a look around to plan this second kind of bigger operation. And from then it was just, they couldn't find my reproductive organs. There was so much scar tissue. The endometriosis had grown into my ureters, into my bladder. My bladder was kind of twisted and out of place. It had infiltrated my bowel, so I had to have some of my bowel removed. So we kind of led up to the surgery, and I decided that at the time, it was understood that I was possibly going to lose one ovary and both of my fallopian tubes, so I decided to freeze my eggs. So I went ahead with that. It wasn't great, it was quite difficult. I had a huge swollen tummy, and it was quite painful. I managed to freeze 4, so it's better than nothing. But from freezing my eggs, I noticed my symptoms just got terribly worse. I think with all the hormones, it just really aggravated my endometriosis. So I went back, and after a few months, I said to my consultant, I said, I think things may have progressed. Things are getting a lot worse now. I was constantly being sick. I was extremely underweight and just really unwell. So we carried out all these scans and exams again and found that it had progressed. So by the time I did get around to having surgery, I had to have a hysterectomy and a ileostomy stoma because of the endometriosis had actually gone through my bowel. So yeah, I'm 5 months post-op and I have no pain. I haven't been sick. I haven't passed out. I can go for a wee without pain, so that's lovely. And I'm due to have my stoma reversed, hopefully in May this year. So that surgery for me, I understand that a hysterectomy cannot cure endometriosis, but for me, if I was to ever fall pregnant, the chances of me kind of that pregnancy failing were very high because of the damage to my uterus, and so I had come to that decision to have the hysterectomy. And the endometriosis had also grown all and replaced all like my healthy tissue in my cervix as well. So it was just everywhere, and it was deep infiltrating. And for me, that was just the right decision. And I don't regret it because I just feel I'm just starting to feel like me again. So yes, seeing a specialist is something that I wish I'd done a long time ago. And I hadn't actually heard of these specialist centres. So I'm always kind of encouraging others to, see a specialist, especially as a lot of mine was missed in the beginning. If it wasn't missed, perhaps things wouldn't have got this far. So yeah, it changed my life.
Thank you very much indeed, Carla, and for telling us so calmly. I'm not sure that all of us will have managed to be quite so collected about the sort of traumas that you've gone through. And I think it's important for me to emphasize to our audience tonight that on average, it takes a woman 7 years to get a formal diagnosis and management plan for her endometriosis. And of course, some women feel that they never managed to achieve that, which is really very tragic. And hopefully by raising awareness, we're going to be able to improve that. Now I'm going to move on to Alfred Cutner, but Alfred, I'm just wondering if you could address one of the questions that's come up already several times in the Q&A, and that is to give our audience a very, very rough run through the 4 stages of endometriosis as you go into your talk. Would that be possible?
Yes, okay.
Thank you.
Thank you. Thank you, Leslie. Well, thank you, Carla, for sharing your story again. And it's a very important story because it shows the journey between a possibility of diagnosis and then, if there's severe endometriosis, coming to a group of individuals that are familiar with managing the condition and are familiar of working together in a team, and therefore hopefully giving a good outcome by working together. And that is what multidisciplinary working is all about. Now, we know that endometriosis is very common. It's about 1.5 million women in the UK. And when we look at the more severe end of endometriosis, it's about 50 women per 500,000 population. So it's not so common, but it's definitely not so rare. It is common enough that you need enough centres, 1 per or 2 per region, to look after the women who have this level of disease. And we often talk about mild, moderate, severe endometriosis, or we do stages of endometriosis of 1 to 4. Now, the staging is very much done from a fertility aspect. And stage 1 is when there are just small areas. And once you have a cyst of an ovary, it upstages it. And when you have deep endometriosis, it makes it more severe. And what we're largely talking about when we're talking about severe endometriosis is stage 4. So it's the endometriosis that involves the area between the bowel and the vagina. It may involve the bladder area, and often there'll be large cysts and the ovaries can be stuck. And you can have endometriosis outside the pelvis, but this doesn't really come into the staging, but is obviously something we need to be aware of. So we treat women for their symptoms, and then we look at it in conjunction with what we find. And when we look at symptoms of endometriosis, we talked last time a bit about fertility, and today we're more talking about pain and other aspects that occur. Women can complain of painful periods, pain on intercourse, pain with the bladder, pain with the bowel. And how bad it is will depend on whether somebody wishes or does not wish to have surgical treatment. There are certain aspects, particularly within severe endometriosis, where we need to encourage people to have surgery. And that's where it starts to involve the ureter. So it puts the kidneys at risk, or starts to develop bowel obstructions and puts the bowel at risk. And Darren and Al will talk about this shortly. Or there's a large mass. But the majority of women will have surgery because their pain symptoms are affecting their quality of life. And Carla has very clearly outlined for us how this can affect quality of life and can stop normal functioning. So it's really important to seek appropriate treatment. What is a centre? Well, the centre involves a gynaecologist, often or always, to help make the diagnosis, together with an assessment unit. And we talked last time about expert scanning, and there's also expert MRI to help make a diagnosis prior to planning the treatment. A nurse specialist is very important, and Renata is going to talk about this, of helping the woman through her journey and also helping the problems as they occur. And then the team doing the surgery would often include a gynecologist with a bowel surgeon and with a urologist, and different types of urologists depending on what's involved. And again, it depends on the extent of surgery and what the aims of surgery are. And there's quite good guidance out there now. And all this awareness has helped with the British Society of Gynae Endoscopy, together with the Royal College of Obs and Gynae, raising awareness and developing centres of excellence where women can come and have this multidisciplinary care. And because of this awareness, NICE developed a guidance which talks about specialist services and how women will move through from mild endometriosis, being treated with simple symptomatic treatment, through to more severe endometriosis, and strongly recommends being treated by a team of experts. And this is very important. And indeed, the NHS commissions healthcare, and it largely commissions healthcare for severe endometriosis by teams of specialists. And when we do the assessment, we try and work out with the woman, what are the aims of surgery and what is the planning of surgery? Sometimes we see and we treat, Sometimes we need to give some menopausal treatment before surgery to make the surgery more straightforward. And sometimes we do an assessment first, as Carla has explained, to help plan what the different options of surgery are. And by having a multidisciplinary service, hopefully we're able to have teams of experts who have adequate training. They have an adequate workload of surgery, because like in all walks of life, if you do something often, you're likely to be better than if you do something occasionally. So teams of people doing something so it's a common thing for them to do would hopefully offer better care. Working together means we can all offer our own expertise and offer advantages. So it's more than just symbiotic, it's added value on top of that. And also the care needs to be offered in appropriate facilities with the correct equipment, because even if you're a good surgeon, if you operate with poor equipment, your outcome's not going to be good. So in summary, what does a centre offer? It offers good preparation for the woman to know what to expect and what the plans are. It allows us to counsel women about what to expect from surgery and what the expected outcomes are, and help her make the choice about which direction she would like to go. It helps offer the correct surgeons for that particular operation. And really importantly, it also offers the correct post-operative care, because all surgery has risks, and the more major the surgery, the greater the risks. And if a complication happens, we want to change it from being a disaster to being an inconvenience. And by having teams together, we will identify problems earlier on and hopefully minimize the adverse outcomes of a problem if it occurs. And for the NHS as a whole, by offering good multidisciplinary care, we actually prevent wastage of resources. But having multiple operations is very expensive. And to offer better care, we offer focused care, and actually it's more cost effective. And more importantly, it offers the woman a better outcome. Thank you.
Thank you very much indeed, Alfred. That was really helpful. And there are lots and lots of questions in the Q&A box and the chat regarding how to access centres. And I know that we can come back and discuss that more in the general discussion at the end. And just to our audience, can I assure you that any of the names of, or the acronyms like the British Society for Gynaecological Endoscopy, BAUS, RCOG, the NICE guidelines, we'll include all of that for you in a follow-up email. And any questions that we're not able to address tonight, specifically if you have a particular symptom or a particular case you want to discuss, we'll aim to respond to you by email after the webinar. And thank you to those of you in the audience who so kindly acknowledged that we've responded to you because of the questions last week in the webinar. So thank you for those kind words, thanking everyone for doing that. So I'm going to move on after hearing from the gynecologist to the colorectal surgeon, and it's a great pleasure to welcome my colleague Alistair Windsor, who's going to share with us his expertise on the colorectal aspects and the management for severe endometriosis. Alistair, the Zoom.
Leslie, thank you very much, and thank you, Weekly, for including me in this. I have to say it's a great initiative to have these webinars and discuss these problems. It is very much to help, I think, rather than so I'm pleased to be here. What about colorectal aspects of endometriosis? And sort of what Alfred was saying is that if you imagine the whole spectrum of disease, there's only going to be a small number of patients that will end up with colorectal involvement. So it's an indicator of a very severe end of the disease. Why does the bowel get involved? What is the problem that makes the bowel involved? And I think that really is just an innocent bystander. So the process is often in the pelvis, and any bit of bowel that can be stuck in the pelvis can be involved in that process. So we get bits of appendix on occasions. The appendix can sit down there, and therefore you can get problems with the appendix. You can get other bits of the colon coming from up in the abdomen down to that area, and they can get involved. But predominantly it's the rectum. That's the bit of bowel that's stuck down in the pelvis, and therefore that's the bit of bowel that tends to get involved. And if you look at how it's involved, it's on a number of levels. It would be lovely to have a diagram to show you, but on a number of levels. But if you imagine the endometriosis can sit on the bowel. So in effect, the bowel is just stuck to it. So that's common, and that's often what we see. Sometimes the endometriosis actually gets into the muscle of the bowel. So it actually gets a little bit deeper, and therefore that can cause more in the way of problems. But ultimately, and I think in Carla's situation, you heard that it can actually intrude into the bowel tube itself, so into the lumen of the bowel, and obviously that then causes obstructive symptoms, and that needs to be managed in a slightly different way. And we'll come on to how we manage those various aspects of involvement. So if you imagine on, in and through is what we're really looking at, what we're really thinking about. In terms of symptoms, and the other theme that I'm going to come up with again and again, it's unpredictable. So you can have quite a lot of bowel involvement and you don't necessarily have the level of symptoms that Carla had. More often than not, there is a significant amount of symptoms when the bowel is involved. And classically, it's this, what we almost describe as crescendo pain when you need to go to the loo. So you get the urge to go to the loo, you get a buildup of pain, and it's only really relieved when you can actually open your bowels. And that's because the rectum is restricted and you're almost passing an obstruction, you're passing a narrowing in the bowel. Equally, you can get symptoms, you can actually go on and get proper obstruction and require emergency surgery, but that's extremely rare. Normally, this is a slow build-up, and so we can begin to predict that there's going to be bowel involvement. I think the other thing you need to remember as well is that many people will have irritable bowel syndrome. So there is an element of additional symptoms on top, and sometimes it's very difficult to piece together which is irritable bowel syndrome and which is, and that's often why you don't get diagnosed, because you get labeled as being irritable bowel syndrome when in fact it's the endometriosis causing it. But it's important, I'll talk a little bit about how it affects the bowels and surgery just in a second, but it's important to remember that even if we do a really good operation and get rid of the disease, you sometimes still have some bowel symptoms at the end because there's an underlying irritability. So how do we assess the disease? And again, Alfred's talked about this, it's a lot of imaging, so it's MRI scans and it's ultrasound scans, and sometimes it's a first look, so you actually do a laparoscopy to have a look, see what's going on. And again, unfortunately, and Carla's case illustrates it, that it can be unpredictable. You sometimes just don't pick up the level of bowel involvement, and until you're actually there operating and doing that bowel involvement, you really understand how bad it is and how difficult it might be, which is why it's sometimes useful. Often Mr. Cutner, Alfred and I will actually do a diagnostic laparoscopy together. So me just there, not expecting to do anything, but really just have a look at the bowel and assess so that we get a good feel for what we might come across later on. What about the surgical approach? And I would argue that our surgical approach has changed hugely over the years, that we started out with me being called when I was needed halfway through an operation, and I'd come in and I'd do a bowel resection because that was the easy thing to do. But we realized actually that was doing some women a disservice who really didn't need a bowel resection. And of course, with bowel resection, there's potential complication, there's potential leak, there's persistent symptoms, bowel symptoms afterwards. So if we could avoid that in some patients, then that would be an ideal, obviously not compromising treatment, but avoiding that. And so what we do now is that we work together. So we start the operation together. So for the difficult cases, it's Alfred and myself right from the very beginning, so that we can begin to, we actually teach each other a lot about what's going on in the pelvis. But so what we're trying to do really is to do the minimum we can do to get the bowel away from the process and improve your symptoms. And so in effect, you can shave the bowel off. So if you get just literally, if it's just involved with the surface of the bowel, you can peel that away. And that's sufficient. And there's no disease in the bowel. So once you've done that, that's often is sufficient. Sometimes you have to take a little disc of the bowel away. When you take a little disc of the bowel away, you have to sew that up. So there's a small amount of risk involved there. And other times, clearly, there needs to be a bowel resection. And in Carla's case, it was bad enough that she needed a piece of the bowel taken away. And again, not that you would shy away from taking away the bowel, but if you do take away a piece of bowel, then there is a risk of leak. We need to recognize that it's young women who are otherwise very fit and well, and this is benign disease. So having disasters with endometriosis surgery is clearly a disaster. So we need to avoid that. And we're very, very careful when you've done a bowel anastomosis, a bowel join. There's lots of checks that we go through. We would only contemplate doing an ileostomy if you really, really needed to, so that if there is a problem with the join, if there's a concern about the join, we even get down to the stage, and I won't get too graphic, but we actually fill the pelvis full of fluid and we actually blow air in the bottom to see whether or not that join is going to be airtight and watertight, so that we can be sure. So we're very, very cautious about doing bowel resections if we don't have to. And if you do a bowel resection, being very clear about when you might need an ileostomy. It's the bit that most patients really worry about. Hopefully we might hear from Carla later, but actually, if you have an ileostomy, you get better very quickly. And it's a safety valve. It's looking after your safety rather than anything else. So I think it is important if you need that to do that. What about afterwards? And so when all of this is over, what are you left with? And there is an element of bowel dysfunction afterwards. It's not, doesn't often go on for terribly long, but everybody will get some bowel dysfunction afterwards. It's not necessarily incontinence or problems like that. It's often erratic and irregular bowels. And you just have, we put you on a gentle laxative and we can help you with those difficult bowels afterwards if you need to. And the vast majority of patients will get back to being pretty normal, aside from if you also have an element of irritable bowel syndrome as well. So you need to be mindful of the fact that there may be some more persistent bowel symptoms. So I think in summary, it's unpredictable. We sometimes don't know what we're going to do, and therefore we talk to you about that whole spectrum of possibility. In our hands, in our practice, we've gone from doing lots of bowel resections to doing very few. We're about 95% shaves now. And that doesn't seem to compromise the improvement in your symptoms, and it doesn't seem to compromise the long-term outcome of the disease. And that's come out of us working closely together over a very long time and looking after many patients like this. So we've evolved the practice in that way. Leslie, thank you very much.
Thank you very much indeed, Alistair. Really, really helpful. Thank you. And now I'm going to move on to Renata Marucha, who's our nurse specialist. Renata, we're all looking forward to hearing from you very much indeed. Thank you for spending the time with us this evening and for all the work that you've been doing.
Thank you. Good evening. I'm Renata. I'm an endometriosis nurse specialist for over 4 years now. I'm working with the team over here. And I'm proud to be part of this team because I think we're a very good team, and it's really rewarding to be able to support ladies with such a severe problem like endometriosis, which affects lots of aspects of woman's life, like fertility, relationships, physical and emotional well-being. So why do we need nurse in the endometriosis team? Because there is evidence women with severe endometriosis benefit from having nurse specialist support. And then the person who understands the condition, treatment options, post-operative care, etc. And what I do is basically about support. So I support women with treatment options, complementary therapies, speak about diets, exercise, all of these things. They don't talk to consultants often. And I try to support the ladies on this, and also encourage to take control of the condition and symptoms when they may appear later after surgery. There's no always guarantee the pain will stop after they finish surgical treatment. So I'm basically women's advocate in relation to surgery and treatment. I see them preoperatively, I see them after surgery, I see them every day, and we speak about surgery outcomes, coordination and appointments on discharge, reassurance, explanation. Is very worrying time after surgery. There's a lot of questions appear in meantime. I also provide follow-up phone calls, and then there's a lot of things coming after surgery. We need to make sure that the recovery is nice and straightforward. So we try to make easier the patient's journey after surgery as well. As the important part of my job is data collection, and including quality of life surveys, which is 6, 12, and 24 months after surgery. We follow up patients' symptoms and we upload them to BSG database website, which is contributing to research into endometriosis. And also we'll be able to follow up patients' symptoms up to 2 years. What else I do? I encourage to engage with support groups, which are very widely working in UK. And then sometimes support groups could be very helpful with dealing with conditions, symptoms. Patients can share experience with others. And then it's very important for some patients, not always work for everyone, obviously. I also liaise with colorectal teams when having patients with stoma. We teach patients how to deal with stoma when they are admitted to hospital. Also refer them to NHS hospitals later on in a local area. They can support them locally with stoma care and things like to encourage them to make sure they support it locally as well. What else I do is a long long list of things I do, but I have limited time, unfortunately. So I'm like a link between consultants and the patients to make sure I'm there for them when they need me for support and assurance. And also BSG accreditation specialist centers is now dependent on having nurse specialists in place because they prove there's evidence. They need a person who supports patients every day from beginning to end of the journey.
Thank you very much indeed, Renata. That's really helpful. And you've emphasized just how important it is to have not just a link, but I call you the linchpin of pulling everyone together. Now, our last panelist is a urologist, an endourologist, and Darren Smith is going to share with us some of his expertise. As you heard Alfred say when he was presenting, when the endometriosis starts to affect the ureters, we know we're in trouble. And that's when we've really got to get some specialist expertise, and we're going to have to do something about this urgently. So Darren, over to you. Thank you very much for coming and for sharing us with your expertise and your perspectives on severe endometriosis.
Well, thank you, and thank you for having me. Having listened to those talks and the stages of endometriosis, as the urologist, I am really stage 4. I'm listening to that and think endometriosis as a whole. Then there's the bit that's adequately severe that it gets referred to Alfred. Then there's the bit that Alfred gets that's severe enough to involve Al. And then if there's the bit that involves the ureters, it's got 3 specialities. So when I'm involved, it's pretty much as severe as it gets. So as Al has explained, in terms of the bowel, it's either on the outside, on the inside, or through and through. So I'm an endourologist, and in fact, I call myself an endoluminal endourologist. Al used the word lumen, that's the inside of the pipe. So when I arrived at UCH about 12 years ago as a stone surgeon, treating kidney stones, just putting a telescope up through the delicate pipe that is the ureter, and that's what basically the whole of my job was. And at that stage, 12 years ago, the surgery for endometriosis, if the ureter was narrowed and involved, then that was probably going to involve a reconstruction, which meant plumbing the ureter back into the bladder in a different position. And has already been very nicely said, if you can do excellent surgery with excellent results, but actually do it less invasive way, you in fact get a better outcome. So as an endoluminal endourologist, what could I bring? And the thing that happened first was lots of discussions. So similarly, we would have calls, can you come and put stents in this patient? I won't talk about stents in very much detail, but our discussions was, what is it on the endometriosis side that makes you concerned that they're going to be required? And actually, as is coming through very well in a theme, it's about the expertise of a multidisciplinary team that thinks in their own individual ways, that comes together in one unit that solves problems almost before they arrive. And I think one of the things that I've particularly noticed in the close collaboration here that I think is amazingly supportive for patients is that each of us are really speaking to each other almost literally every other day. So when there's a patient who's at the beginning of the journey, we're hearing about that before we've met them. At the same time as having that discussion, we're giving updates about people who are halfway through. So the sort of collaborative learning has been really speedy. So my role is mostly of prevention. So when the rectum has to be looked after and dissected free carefully, the ureters are very, very delicate pipes draining the kidney. So my role really is try to avoid reconstruction, keep my open urological surgical colleagues out of business. And by doing that with telescopes, putting stents in, help to identify the ureter, but most of all, help to protect their drainage afterwards. And having looked at literally hundreds and hundreds of cases through our NHS practice at UCH and all of those at King Edward's, we have, fingers crossed and touch wood, with this preventative approach, managed to avoid any major urological problems. So that's a brief summary of what aspect a urologist like me brings. But I think the take-home message is it's all about the way that the team comes together. So thank you for having me on your panel.
Thank you very much, Darren. And can I ask you a couple of things? How do you know whether stents are needed? And that's probably a very basic gynecological question. And then how do you judge when that's going to be sufficient, or whether you're going to need to do something much more invasive and potentially risky?
So the first bit is in the pre-operative workup. So if any of the scans, as has been mentioned about, expert radiologists, the key to all of our work is reconnaissance in advance is never wasted. So imaging is key. So if a kidney is dilated on imaging, or indeed if the patient has got pain in the loin, then that sort of raises the ante by one level. Most times that is normal. If it isn't, then obviously a urologist gets involved early, either for symptoms or for imaging. Then, as Al has said, the first stage in working out how complex endometriosis is going to be managed is with a diagnostic laparoscopy. So if the disease of the endometriosis, a nodule, is involved in that space between the rectum and the vagina, that's where the ureters are going in. So it's highly likely that the ureters are going to be close by. We know where they're supposed to be. So then we'll put in the stents as a preventative for identification, either at the beginning or at the end of the operation, depending upon how it's been planned. So it's about the knowledge that has already been gained, so that you can work out, which cases are more likely to have a problem. The reconstruction element, so the bit that I'm trying to keep out of business for the benefit of the overall recovery, is that if before the operation the kidney is dilated and on a functional study, an isotope test, a MAG3 as it's known, if a kidney's lost function, then that's most predictive that a reconstruction is going to be required. But even then, we still sometimes get away with it.
Thank you very much. So caution here is really important to the long-term gain. There are lots and lots of questions. I wonder if some of our panelists would like to respond to what is the strongest theme through our audience's queries, and that is, how do they go about getting a referral to a specialist centre, particularly if they're not based within a stone's throw of UCLH or King Edward VII. So I know that last week we were able to put up onto the email correspondence to our audience details of where you can find lists of the centres around the country. But Alfred, would you like to take that one and then possibly pass over to one of your colleagues who wants to add to it?
Yes, I mean, the raising awareness and the raising of NICE and the BSGE and the RCOG and other organisations has enabled the development of centres. And it is now, NICE would say, if a woman has proven severe disease, she should be managed within a centre. And that is how the NHS commissions its healthcare now. And if you go onto the BSG website, and we gave the details last time and we can give it again this time, you can see a list of those centres around the country. And if a woman has proven severe disease, then she should ask her GP to send her to a centre, or if she's in secondary care, she should ask to be referred on to a centre. And most gynecologists in secondary care would be keen to refer on because it's not within their comfort zone, and they would rather the woman be treated in a centre where we bring this excellence together. Unfortunately, at the moment, because of COVID, there are very huge delays. And of course, the massive development of centres and the greater prevalence of them and the more availability has all come to a halt because of the coronavirus pandemic. But until that point, we were progressing very well. And there will be a backward step, without a doubt, unfortunately. But that should hopefully, as things settle down and healthcare comes back online, should improve again. So the centres exist. Whether they are accepting all of them at the moment is due to the fact of the coronavirus pandemic, not due to a lack of desire to provide care.
Thanks, Alfred. And there are quite a lot of questions about the problems with bowel preparation and the need for a stoma or an ileostomy. Alistair, would you like to give us some sort of wise words about this? I know,
Yeah.
I know that every case is individual, but I think there are lots of questions about it, and it's something that I think many women are very frightened of.
Yes, I agree. And I think certainly the ileostomy. So let's just cover the bowel prep side of things first. And it is a big debate, even in colorectal surgery, when we're doing bowel cancer resections and things, or taking bits of bowel cancer. Do you or do you not need bowel preparation before you have your operation? Our feeling about this is, first and foremost, bowel preparation makes it easier to work with the bowel. And not to be too graphic, but if you've got a lot of stool in the bowel, it just is difficult to move it around. So it makes the operation easier. And I think that what we're worried about at the endometriosis level is sometimes even accidentally or having an inadvertent problem with the bowel. And if you have a lot of stool in the bowel, that could be very dangerous. We don't always do a bowel resection, but we always do bowel preparation. So again, it's all about safety. They're young women, benign disease, you don't want to do any harm. So it isn't very pleasant, and I've got some tips and tricks about how to make bowel preparation slightly more pleasant if anybody ever wants to ask. But so I think it is important, and it's something that we need to do. The ileostomy side, very briefly, is it's the most, and that's the one thing when they come and see me, when the patients come and see me, that's the thing they've focused on. They've often seen Alfred first. There's often been a brief discussion, and the one thing they take away is, am I going to have a bag? All I would say is it's rare. And be absolutely sure, certainly in our hands, that if it is there, we have a team that will help, people like Renata, and we have a wonderful stoma team who will help you manage and look after it. You'll hate it for a couple of months, but it might well have saved your life, and it makes you better much more quickly. You get better and get going much more quickly. And the vast majority of people have a very simple, small operation to put it back afterwards. So I would try and say to people, don't focus on that. If you need it, you need it. We'll manage it. The vast majority of patients don't need it, so I wouldn't worry about it. Yeah. Can I just grab as well? Can I just grab? There's a couple of other one lady's asking, Kate is asking about the fact that she is worried now that she's been told she's got in bowel involvement further upstream and not where she would expect to have it, which is down in the pelvis and the back of the vagina. And that is just the way it is. That's the idiosyncrasies of endometriosis, that you can often get bowel involved remote from where it is. So, and in fact, to be fair, it's sometimes easier to manage that bowel. So for Kate, if she's there, then do not worry about that. It does happen like that sometimes, and sometimes that makes it easier to treat.
Thank you very much indeed. Thank you. Carla, are there any other questions that you would like to pose? I think there were quite a few literally targeted to you, as well as the admiring comments from many of our audience thanking you for sharing your story. But I think you thought there were a couple of things you'd like to address. Please feel free.
Yeah, I think for me, I was so worried about having the stoma. It was kind of spoken about for a little while, and I was having panic attacks. I was just trying to find a way for this not to happen, and when I did wake up and I kind of saw it for the first time, I did faint. I fainted a few times, but it's not that bad, and I can say that now. I'm a couple of months on. It's really not that bad, and you just, when it really does come down to it, you just appreciate not being in that pain. And the risk of not having the bag and leaving it there also can be really dangerous. So, and I know it's reversible, and most of the time it is reversible. So I just wanted to say not to kind of panic, because I panicked, and I was a complete wreck. And I feel a bit silly now to how I felt before, because it's really not that bad. I also had the stents as well, and yeah, I know Darren Smith was talking about those. So I just, yeah, it saved my life. So just that side of things, yeah, I just wanted to just don't panic.
And as Alistair was saying just now, you know, if you do have to have a stoma, temporary one, it's because you have been so very unwell. And let's just keep focusing on the fact that it will really speed up your recovery from what's been quite a traumatic time. Thank you very much. Alfred, there are quite a few questions about fertility. I know we covered some last week, but you might want to make some comments about, there have been some comments about very extensive endometriosis, having a frozen pelvis. What can we do about that? You know, when should we take action? Be thinking about egg freezing or fertility treatment. Do you want to make some overall comments for our audience tonight?
Yes, I mean, we talked about fertility last time in the context of mild and moderate endometriosis. With severe endometriosis, in reality, the best outcome will often be IVF. And if the tubes are blocked and dilated, then of course IVF is the only outcome. And when we free everything up, one of the risks are that we could damage the ovaries, And one of the problems of treating cysts on the ovaries is we damage the reserve, the amount of ovary that's left functioning. So when somebody is concerned about fertility, either for the future, as in a woman whose family isn't already complete, then we need to think about, should the eggs be preserved before the surgery or after the surgery, should they go to IVF? So there are different ways of treating. The woman can have surgery and then go to IVF, maybe go to IVF and then have surgery, but it may be that the pain is so bad that that's too difficult. Or we might do a first stage to assess, collect the eggs and store, then do the rest of the treatment, and then have the embryos put back. Because what we don't want to do is for the woman to have her ovaries run out because of our surgery and because of the endometriosis before their treatment is complete. So it's timing storage in conjunction with the treatment. And we're always trying to say, is it pain the issue or is it fertility issue? And trying to prioritize what is the most important at that time. So
treating the patient and her symptoms and not the textbook.
Exactly.
Really, really crucial. Absolutely. And that's where this specialist centre is so important, because it can individualise care and really look after the woman holistically. Some further questions. Alistair, there's one or two ladies on the chat talking about the fact that they're due for bowel surgery and they would like your top tips for bowel preparation. So I don't know if you can.
I wish I hadn't. Very simple. So most bowel preparation is high volume and therefore, and it's horrible goop that doesn't taste very nice. So the most important thing is to get it cold. And so my top tip is, if you get an orange cordial bottle, a litre orange cordial bottle, and leave a little bit of the orange cordial in the bottom of it, make up your bowel prep and pour it in the orange cordial bottle and mix it. So you've got a bit of flavour and you've got a litre volume, and put that in the fridge and leave it in the fridge for 5 or 6 hours until it's really chilled. And then it's much, much easier to sip, and you can sip and sip and sip. Don't try and gulp the sort of slightly warm room temperature stuff. It really is very difficult. So my top tip would be a bit of flavouring and very cold from the fridge.
Yeah, try to pretend you're having a gin and tonic or a gin and orange. Okay. All right, then. A question here about pelvic floor Botox being very helpful after surgeries done by my very experienced urogynaecologist. Now, which of you would like to take that one?
Well, I'll just, it is interesting, isn't it? So I would argue that what they're worried about there is either functional problems, in other words, not being able to pee and not being able to poo, or having pain in the pelvis. And we know that after you interfere in the pelvis with nerves and everything else, you get a lot of pelvic floor spasm. And that can create all sorts of difficulties with evacuating. And we see it very much, patients being unable to go to the loo after surgery because they have a lot of pelvic floor spasm. So we use a lot of Botox. I mean, I know urologically they do as well, but we use a lot of Botox in the pelvic floor for people who have difficulty with evacuating or pain from pelvic floor spasm. So I imagine that's what they're looking at. Not everybody would get that and not everybody would need it, but it would be part again of that sort of multidisciplinary team to try and access if you needed it.
Thank you. Thank you very much indeed. And as I say, we've had so many questions about individual cases feeling very distressed because it's taken so long to get a diagnosis. So we'll be able to put up the specialist centres across the country onto the email chat for you, so that all of the audience can access that. And there've been quite a few questions, and this is now asking Barney Baxter, asking whether these recordings are going to be accessible later. And they've certainly been recorded, I know that, because quite a few people have told me that they've watched them on catch up. So Barney, would it be possible to share the recordings with audience members that apply to you for them? Well, I'm going to assume that the answer is yes.
Yes, Leslie, I'll send them through tomorrow via email.
Lovely, thank you very much indeed. And you're going to have a very busy day tomorrow, Barney, because there literally are an enormous number of questions, very specific questions. And as I said, our wonderful panelists were really good to us last week and actually provided answers for everybody. Now, just a couple of other things. I'm possibly going to go to our panelists in the last 3 or 4 minutes and just ask them if there's one other last thing that they would like to contribute to this webinar. there are the appreciation is very overt on the chat and in the question and answers. People are really very delighted and thanking you for your expertise and your interest and your commitment to this really difficult area. So starting with Carla, was there one other point you'd like to make before, just as we round this up?
No, I don't think so. I'm just thankful for this event. I mean, I just wish that I kind of tuned in and listened to something like this many, many years ago. You know, for me now, it's kind of, I'm out the other end. I've had the hysterectomy and, you know, the infertility and the stoma. And so, yeah, I just hope that this helps, you know, many other people.
I'm sure it will do. And we really are so appreciative of you, not just giving up your time this evening, but last week as well, and sharing what must have been a very difficult journey, and also giving everybody such optimism and positivity about what can be achieved with the right people to support you. So going through, Renata, is there anything else you'd like to add? I think I was saying earlier, I think your role is pivotal as the linchpin pulling everyone together. Anything else that you'd like to add to our audience tonight?
I just need to say thank you to Carla, who shared her story, and we encourage our patients to not afraid to come for surgery and treatment for endometriosis, and also not afraid of stoma and this sort of things. Thank you, Carla, much appreciated.
Thank you. Darren, from the endourologist point of view, thank you you explained that you're almost the man of last resort, but obviously very, very valuable when that last resort is reached. So any other comments you'd like to share with our audience?
I think my observations and experience that by the time that you as a patient have reached, as has been seen in some of the Q&As, you know, the daunting prospect of major surgery a day or two away, and you might have stents and you might have an ileostomy, and it must feel absolutely dreadful. But you should be reassured that you've already survived on average 7 years of dreadful things, and in fact, you know, you're now almost already into the home straight. You're going to be kept busy over the next however many weeks and months with the operation, the recovery, the stents coming out, the stoma being reversed. But nobody can put a story better than a patient who's gone through it all and is able to smile the other side. So that's what you've got look forward to. So you're already in the home straight.
Thank you, and thank you for that uplifting end. Alistair, any comments? I have to ask you, as the colorectal surgeon amongst us, quite a lot of questions about diet here. Do you have particular tips about diet or problems, for example, like some people say their gluten intolerance got worse, some say it got, you know, the opposite. So any comments you've got about diet?
I would say, first and foremost, don't worry that there's going to be a problem post-operatively. Everybody gets change post-operatively. So don't be rushing to change your diet and go whatever you would normally do. Plenty of fluid, plenty of fruit, fluid, fiber is the 3 Fs, as it were. And I think that a lot of those acute changes, those early changes will settle. If you still have trouble, that's when you need to come back to see somebody like me, because there are a number of other issues which are probably coexisting, which we mentioned. So irritability, and it would be worth going through all of those things. So I think it's teasing out what is endometriosis. We can fix that with an operation, and what then is IBS or whatever else, and that would be the time. But don't do it immediately. Give it, you know, sort of 8-12 weeks before you rush and do anything different.
Great, was excellent advice, and another top tip there. So Alfred, I'm going to give you the last word as the gynaecologist. Thank you so much for all that you've done. I think one of the things that is also coming up a great deal in the Q&A and the chat is that the importance of MDTs and discussions, and I think what you've demonstrated to us this evening is that the three of you, when you're operating together, spend more time planning, if I may say so, than actually doing the surgery, which is obviously crucial and possibly something that our audience weren't really aware of, the importance of debate and discussion about how best to look after someone. Would you like to make some final comments? Because it's after 8 o'clock now, but you have the last word.
Thank you, Leslie. I think the important aspect is the teamwork, and it's the MDT, and it's the formal MDT can be discussing somebody's notes, but the real MDT is the discussion one-to-one, and half of the MDT is during the operation, where surgeons who are used to working together, they know the different outcomes from having worked many times together, and they're discussing as they go along, because no two people are the same. And so we must individualize care by a team of specialists who are used to working together, who know what the different outcomes are likely to be, depending on what decisions will be made. Thank you very much.
Thank you, Alfred. So with that, I'm going to, on behalf of you, the audience, I'm going to thank our fabulous panelists. I think they've done a really wonderful job. They've been highly informative and really responsive to the questions, warts and all, as they would say. And I think that's been really, really helpful. As I say, the appreciation is very, very manifest on this chat and the Q&As. We will be offering you the recordings both of tonight and of last week's webinar on the email circulation that Barney is going to be spending a great deal of time, I think, tomorrow addressing. We will aim to answer all the individual questions about cases, and in particular, so many of the questions have been focused on how can I access a centre, or how can I just initiate the process of being looked after. And I hope you've developed, audience, some insight into the possibilities, and just the fact that you can go and ask to be referred, and that there is specialist commissioning for this with NHS England. So with that, I would like to thank the panelists again, Carla and Renata, Darren, Alistair and Alfred, and I'd also like to thank the King Edward VII team. Barney, thank you for putting it all together. Thank you for cheering us up to the rehearsals and getting all of the hosting correct. And thank you to our audience for being so responsive and so appreciative. I hope that this will, well, this is the second of our King Edward VII Women's Health webinars, and I hope it will be heralding many more to come in many different subjects in the future. So with that, I'm going to wish you all good night, and thank you again for your time and for joining us to talk about such an important topic in women's health. Thank you and good night.